get through this in 2 hours or less. So let's talk about some clinical applications of the cerebrum. We're going to just go through various lesion locations and just talk about the type of symptoms you're going to see with some of these lesion locations. Tomorrow we'll focus on actual lesions to specific vascular territories. Well, some of these are associated with certain vascular territories, but we're just going to focus on just general location right now. So thalamic injuries, anytime you have damage to the thalamus. So some of the things you're going to see with that is contralateral sensory loss, right? When you're up in the thalamus, if you damage, say, that VPM or VPL, everything's crossed over, same side of the face and body, primarily just sensory, okay, on the same side of the face and body because of that damage to the relay nuclei. This is the one I added to the this morning, is thalamic injuries. They don't know exactly. They're usually in the posterolateral part of the thalamus. Is this thing called controversive pushing or lateral pulsion, or it's also called pusher's syndrome. And it could be because of damage to the relay nuclei for the vestibular system, okay? And the person does not understand vertical, and they perceive their vertical for their body to be different from vertical orientation to gravity, okay? And so they'll literally be leaning and pushing sometimes towards their weak side because they have this strong sense that they need to be over here to be straight up. They're perceiving the environment and gravity different. And so that's part of that is processed in the thalamus from the vestibular system that gets relayed eventually up to the cortex. So these patients, you'll be sitting with them and they'll literally have their strong arms. So let's say they have a stroke and they have their left side is weak. The stroke would be on the right side in the thalamus. And they would literally be sitting on the mat table, pushing with their good arm and leg, pushing themselves over. And then when you go and try to help them and you say, straighten up, if you put pressure through their shoulder here to push them over to the other side, the harder you try to push them over, the harder they just push into you. And because they're totally resistant, they think they're being pushed over the other way. So their body is just totally resisting that motion. And it's just like this fight, you know, and you're like, come on, just don't do that, quit pushing. So there were some strategies. One of the strategies is like I take their hand and leg away from them and like either snap it, but I make sure it's not on the plinth or not on the ground. Sometimes I'll put their good leg up on a ball or something, so or raise the plinth up so their foot can't hit the ground. Take their arm away from them so they can't push towards that side. And then the other thing I do is I try not to give any tactile input to that weak side. So if I'm going to correct their posture, I come over to their good side and try to reorient them by pushing this shoulder this way versus touching this shoulder, because then they want to push into you. And so usually you can find a way, but even putting a mirror in front of them, they'll sit there and they'll know, like you put a little strip of tape on the mirror, and I'll tell them to line up with that. And I'll say, can't you tell? You're like totally, you don't even see your face in the mirror. You know, you got one of those narrow mirrors, and they still can't perceive that they're not vertical. It's a really odd kind of thing. So it usually goes away, but it can have some lasting effects, and it can slow down the initial rehab process. So if you're seeing a patient, initial rehab, they come down with that pusher syndrome, your goals are going to be probably longer to achieve those goals. Maybe the discharge is going to be a slower process, so they're going to have to go to a certain level of care that your patients who don't have that wouldn't require. Occasionally, a small lesion in the thalamus can lead to this very unique perception called thalamic pain syndrome, where they perceive pain on the whole side of their body. Okay, opposite side of the body, and have this just unrelenting neuropathic pain that's associated with an injury to the thalamus, as opposed to actual numbness or lack of sensation. They have excessive pain. It tends to get better over time after the initial insult or stroke. This is just an MRI image showing, yellow here, this is your thalamus on each side right here, and this area here, that white area, that's the lesion. That would be a pretty classic lesion in that posterolateral thalamus. It could be near that VPM, VPL region that would cause contralateral sensory loss. Subcortical white matter lesions. So these are lesions that are subcortical, beneath the cortex in the white matter. So you're affecting axons, corona radiata, internal capsule, the one that really is a bad one is that internal capsule lesion, because it doesn't take a big lesion to affect a lot of axons because they're all right there next to each other. So just for reference here on this, this is anterior and this is posterior in this picture here. This is a thalamus right here. Here's your putamen and globus pallidus they're showing there. This is the caudate, head of the caudate here. This is your posterior limb of your internal capsule. This is showing you face, arm, leg, and trunk. This is all motor. Right behind it is where the sensory, and it's also layered in similarly in that sensory area. Okay, and so this is where you can have deficits that are out of proportion to the lesion size. Okay, so a small lesion, sometimes it's referred to as lacunar. A lacoon is just a small circumscribed area, a little pockmark or pocket. And actually, if we look at when we take a brain out and we do a cross section through it, a lot of older adults have little lacunar infarcts that if they're in an area, they're small enough and they don't affect one of these particular areas directly of weakness or numbness, they may not even notice they have them. Okay, but if it hits the right spot, then it can be an issue. An interesting thing that can, this is something you might see if you're working in pediatrics more so, although somebody could obviously live with this, is a damage to the corpus callosum. You could have damage to the corpus callosum with an anterior cerebral artery, which we'll talk about tomorrow. It lays right on top of the corpus callosum and supplies that region, so you could have a callosal injury. The deficits with a corpus callosum injury are almost imperceptible unless you put this person in a very contrived situation to expose those deficits. And so for some children who have intractable seizures where it's, your seizure starts in one location, then it spreads to the rest of your brain. The one way it spreads from one side to the other side is via the corpus callosum. So there we'll do a procedure called a collosotomy, where they'll actually cut the entire corpus callosum in somebody, so split the two hemispheres. And believe it or not, these people, you wouldn't know that they have a collosotomy unless you put them in a specific contrived situation, which we'll show you here in a second. Initially, when you do the collosotomy, they have some conflicts with hand function and figuring out how to get their hands to work by manually and like, all right, which one is supposed to do this and that? But those get better over time pretty quickly, especially if you do this in a younger child. Their nervous system's more flexible. But then they have normal performance on the neuro exam after compensation. But here's the specific environment you could put them in. As long as somebody can use both their hands and use both of their eyes, then you can't pick up the collosotomy. So this case, what they're doing here is they have this special box, and this box has a little panel that comes up into their field of view too. And behind them, they have a projector, and they can actually flash a word or letter onto the little panel that's in front of them. And they flash it very briefly so that they can't deviate their eyes to look at that word. They will only see it in one field of vision, either their left or right field of vision. Okay, and so in this case, if they were to flash this thing that says ball right here, it would only be in his left field of vision, and because it happens really quick, and then it goes away. So they can't look with their both eyes to get that image into the right field of vision. So it's happening. So except your visual fields overlap some, right? I don't know if you remember from the visual lecture that you have your left and right visual field, eye visual fields that overlap some in the middle. And so if you flash this thing too close to the middle, you might catch some of that with what's coming into this eye. So they keep it way over here. I mean, your field of vision, you've got some of that coming from your nasal field of vision. Maybe we'll do this tomorrow. I'll review fields of vision and those little deficits that might be helpful. But anyway, so all of that information on this left is going to go to my right occipital lobe, okay? But I got to make sure it's far enough away because there's some overlap. So it's out here on the side. So you'll see this image of the ball gets here to the occipital lobe on the side. Normally, if your speech center is on the left, in order for you to recognize that image and to understand that it's a language and that image says ball, you have to if it only happens in your left field of vision and only goes to your right occipital lobe, you have to use the corpus callosum to send it to this side to go to the visual association areas on the left and Wernicke's area to understand that that is a ball, and then to be able to speak it and to say ball. In this case, the person actually will oftentimes say they didn't even see the image because they couldn't recognize the image and there wasn't that transfer over. So, I mean, they could have seen something, they saw something, an image got there, but they may say they didn't see anything because they can't even recognize that as an image that is meaningful in any way. However, subconsciously, if you ask them to reach for objects inside this box, so inside, so they've got this box and this is closed, so you can't see inside it, you reach in, they may be able to, since your right hemisphere controls your left arm, and this image got here, and they say grab an object that corresponds to even what you maybe didn't even see or thought you didn't see, they can grab the ball. And because they can manipulate that ball, and all that information is coming over here to the parietal association cortex. Here's the primary sensory strip here, but it is going to that same side that image got to. So they can still pick out a ball, even though they think they didn't even see the word ball and they can't repeat what they saw, but you ask them to grab the object that they feel compelled to grab, or feel those objects, and they can tell that they'll feel the roundness of the ball, but they won't even be able to tell you it's a ball because they still can't transfer the stereognosis and the perception of the ball over to the speech centers to say ball. Does that make sense? It's really kind of crazy. But you really have to kind of put them in, like I said, this contrived type situation. If you let them touch it with their right hand, they could. If they grab that right hand and it goes over to that side, and they could say ball, because it would be all that information be coming over to this side. Then they could process that, and in their speech centers, they could say ball if they felt it with their right hand, because all that tactile information is on that, getting to that side. Okay. So now we're going to talk about disorders of specific areas of the cerebral cortex. So if you damage the primary sensory areas, that post-central gyrus specifically, you're going to have a decreased ability to discriminate the intensity and quality of the stimulus. Okay, so you're just going to feel like your arm or your leg is kind of that dead wooden kind of sensation. You may not be totally numb. I mean, you have some sensation, but it just lacks fidelity, lacks, be able to discriminate that intensity and quality. You're going to have primarily where it affects is this localization, that fine localization of touch and proprioception is the thing that's most impaired, is the ability to say, you touched me right there. You feel something, but it just feels kind of dead and wooden, and I can tell you're touching my arm, but I can't exactly tell you where on my arm you're touching, okay? Crude touch is not so much affected. That's why you still kind of feel this, because that's more processed in the thalamus, because remember you have the thalamus and some of those spinal thalamic, spinal meniscus structures carry some crude touch in them as well, okay? If they do like pinprick, if you do pinprick on them, they still actually have a reasonable ability to tell you where you touch them with pinprick, because your association cortices, just behind that primary sensor strip, specifically for pain and temperature, it does more of the localization, where proprioception localization is more in that primary strip. So then if we move back into the sensory association areas, okay, so back into this region right here, this is where you're going to have things like astereognosis. Astereo is lack of stereognosis. They're going to have difficulty recognizing objects if you put it in their hand on the opposite side. So this is a right-sided lesion here. If you put that object in their left hand and had them try to manipulate it, they're not going to be able to tell you what it is. They feel it probably pretty well. They might have some difficulty with some pain and temperature localization. They still have pain and temperature sensation. They have proprioception, but they just can't tell you what that object might be. If you damage some of these regions here, this visual cortices, the association cortices, you might have what's called visual agnosia. Visual agnosia is like a visual inattention. So you're not blind. It's just that you pay less attention to what's over. If this is a left-sided lesion, this would be a left brain right here, left-sided lesion, then I would be less attentive potentially to visual information coming in from my right side of my brain. And I might not be able to do, like, construct images to make sense of my world quite as well because of those association areas being involved. So that's visual agnosia. You can also have the same thing if your auditory systems. If you damage in the temporal lobe, this area here, that secondary auditory area, that auditory association area, and that's where, again, that would be, you'd have receptive aphasia. You know, you have difficulty understanding languages and sounds that are coming in, classifying those sounds, and being able to take in information, especially if it's on the left side. Though this would be much worse if it's on the left side of your brain than on the right side of your brain for the receptive aphasia. Really, it would cause a form of Wernicke's aphasia. Now, from the motor standpoint, let's talk about the motor planning areas. So the motor planning areas are the places in front. So the supplementary, the premotor area, and then Broca's area. Broca's area is motor planning for speech, okay? If you just damage motor planning areas, you tend to have this somewhat unique form of deficit called apraxia or dyspraxia. In the States, we use the term ataxia. Sometimes in the UK and so forth, they use the term dyspraxia. I'm going to show you a video here where they call it dyspraxia. It's the inability to perform movement despite normal sensation and normal motor output capabilities. So if you do a manual muscle test on these people, you can just say, hold your arm, and they'll be fine. They'll have good motor strength, okay? And their sensation's not impacted at all because you haven't done any damage to the sensory areas. This is premotor and supplementary motor planning areas. But they can't plan movements very well. They can't, like, you ask them to do something voluntarily, and even though you just tested their muscle strength, they can't initiate the movement or not sure how to accomplish the movement. So they look kind of like they're you know, kind of struggling with, like, coordination in a way, but it's not. If you do this, like finger to nose, they don't have ataxia. They just, like, I'm not sure how to get my finger to my nose, and you know, and you might have to guide them or show them, but they're not, like, doing this. They just, you know, and they might scratch their head automatically. You tell them to bring their finger to the nose, and they don't follow your command, and they don't know how to do it yet. They'll spontaneously scratch their head. And you're like, wait a sec, you know, it looked fine, but they couldn't, you know, do it on command. So there's different types. There's ideational, ideomotor, constructional, dressing apraxia. There's different, you could say et cetera, because there's different types of apraxia depending on where that lesion is and the area that affects. You can get these unique things. So ideational apraxia is literally where they can't even get the idea of how to do something. Like, they can't even get the thing started. Like, you give them, you know, like, let's say you lay down a hairbrush and a toothbrush in front of them, and you say, brush your hair. And they just look at the objects, and they're not even sure what to do with them, or even they don't have the idea how to even get started. Yet you might see them, again, rub their face, get up and walk, move their arms spontaneously, but you put a toothbrush and a hairbrush and say, use that instrument how you think you would normally use it. Like, you'd expect them to pick up the toothbrush and brush their teeth, or pick up the hairbrush and brush their hair, and they don't even know how to get started. Even though you just tested their manual muscle testing, it's hard to do manual muscle testing on them, though, as well, because they have a hard time following that command. So it's hard to get them to do a manual muscle test effectively. But you just can tell that, hey, they move, like, kind of spontaneously on their own, but I can't get them to do this. Ideomotor, you put those objects in front of them, and they go, huh. And they might pick up the toothbrush, though, and scratch their back with it, or try to comb their hair with the toothbrush. Use it in the wrong way. So they have the motor ability, and they try to use objects, or they try to do the task, but they do it poorly or wrongly, not because they're weak, not because they lack coordination. They just don't know how to use that instrument or how to plan that movement effectively. So like constructional apraxia, it'd be like sometimes they might have trouble constructing something, like if you told them to draw a clock and they wouldn't put all the numbers around it, or they'd be in weird places and those kind of things. Or you ask them to make a bed and they wouldn't know how to make a bed in the right order, you know. Or you tell them, do they have dressing apraxia? They might put their pants on and then put their underwear on over their pants, you know, those kind of things. That's a dressing apraxia, which is, those are all forms of ideomotor apraxia. You know, those kind of fall, but they're specialty areas. Sometimes you only pick it up under these unique things, and the OTs get a lot involved with some of those kind of things. Another thing that can occur if you damage some of those premotor areas is motor perseveration, where they'll keep doing the same thing over and over and not know how to turn it off, even if it's unsuccessful. Like I have a patient, you know, like trying to do sit-to-stand transfers, and a couple years back, and every time he'd try to do a sit-to-stand, he would struggle and he'd fail. He'd try to get up and he'd fall back down, and then he'd just keep going, and it got worse and worse, and he would just perseverate, and I physically had to say, stop, you know, quit trying, you know, because he kept trying and trying, and then he'd get worse and worse, and then he'd just perseverate. And he actually would perseverate when we'd be walking around, and he'd catch his walker on a corner or something. He'd just sit there and just bang that walker like this, and not actually, he couldn't really correct the task. He just kept doing it over and over again wrong and couldn't figure it out, and he just start perseverating on things. So that's motor perseveration. Broca's aphasia is a motor planning area for the speech centers, which we'll get to in a second, show you some aphasia. But let's show you a video here, hopefully the sound. Let me just see if got some sound here. We'll keep our fingers crossed that it works. Okay. Let's talk about primary motor cortex now. This is where we're going to have contralateral loss of movement, especially movement fractionation. So if we've got that primary motor strip damaged, they're going to have especially problems with distal control and fractionation of movement, whether it be at the foot, ankle, hand, if you involve that whole primary motor strip. Okay, it's hard to actually involve the cortex, the whole primary motor strip, because that's a big area. You have to have a big lesion, and if you've got that big a lesion, you have other issues that continue consciousness and awareness and other things. So usually it involves a vascular territory, which we'll talk about tomorrow, that affects maybe more of your face and arm, if it's more of a middle cerebral artery stroke. If it affects more just your leg, then it's probably more of an anterior cerebral artery stroke. These people will still be able to move, you know, even if you do damage. So their shoulder might be able to move. You'll see them do this, but it'll be in this synergistic pattern where they're using more of those medial activating systems, those pathways that start in the brainstem. You don't typically damage all of those area, the whole area, so there's usually some cortical influence still left, and it may be, you know, they can move their wrist but not the rest of their elbow or those kind of things, but they'll still usually have some movement. They'll have high tone. This is an upper motor neuron problem. Okay, if you have damage to the facial area and tongue area, which is going to be that area right down, right down here. This is Broca's. If you damage this area, which oftentimes you get damage to both, if you just damage this area, you're going to have aphasia, expressive aphasia. If you don't damage that area and just damage the primary motor strip for your face and tongue, those cortical bulbar tracts that are going to go down, you're going to have weakness on the opposite side, and you're going to have weakness next to their lip. You know, you'll see their lip drooping down, their tongue movement will be impaired, but they can plan. They know what they want to say, and you can tell they know what they want to say. It just comes out like this, and it's kind of droopy and so forth. Now, if the damage is in the brainstem to the actual cranial nerves that go to your larynx and pharynx and tongue, that's called a flaccid dysarthria. And when you have flaccid dysarthria, you have pretty profound weakness and flaccidity in those muscles, and they'll actually have like drooling, and it's really hard for them to keep from drooling. If you have a stroke up in this area, initially you will kind of have that, because remember, we go through a period of like kind of neuronal shock. So if I damaged up here in the brain, initially it will be flaccid, but then eventually it might get more spastic in nature. And then they have a spastic dysarthria where the muscles are tight and rigid, and it's more like this than a flaccid, and then everything's just kind of falling out of their mouth. So anyway, there's just some subtle differences there. But that's where you get into like dealing with speech therapists, and you say, hey, what do you think this patient has? Sometimes I'll be confused. Is this an expressive aphasia? Is it a dysarthria? Is it a spastic dysarthria versus a flaccid dysarthria? Those kind of things. And that's where you want to be careful about in your notes and so forth, diagnosing aphasias and things unless you feel really good about it, because you want to talk to speech therapists to make sure you're not classifying or calling it the wrong thing, and it can get a little complicated. Prefrontal, the prefrontal area, association cortex, so this area all up in here. This is where you have loss of executive function and divergent thinking. They can't think outside of the box. They're very one-tracked. They can't make great decisions in the first place. However, it has minimal effects on standard tests of intelligence, like doing calculations and those kind of things, or even like short-term memory, and those things are not too impacted. This is more like, where you ask them to do something like, if there was a fire in your room, how would you deal with it? And they would have a hard time telling you, well, at first I would pull the fire alarm, and then I would close the door, and then or if you give them kind of a task to do mentally, to think about a sequential task and how to do it, or if you told them this is one way you can do it, now tell me another way you can do that task, they'd have a hard time coming up with various ways to do it. So parietal temporal association area, so we're this area now. This is where we can have this Wernicke's aphasia, especially on the left hemisphere. Okay, Wernicke's aphasia is receptive aphasia, so that's generally this area right here. But we can have some of that Wernicke's aphasia with damage to this auditory association area down here, but really this whole area from all the way up into here are all involved with that receptive aphasia. Okay. If it's a right hemisphere lesion, this can lead to difficulty with directing attention, comprehending space, understanding nonverbal communication, especially with things that are the comprehending space and difficulty directing attention. That's especially going to be true to the left side of their environment. Okay, if it's a right-sided lesion, they have a harder time with the left side. And actually, that controversive pushing I was telling you about, that tends to be even worse and more common in right-sided lesions. So they hit the thalamus on the right side, or some of these regions here, this Wernicke's and association areas, that they have some controversive pushing can come along with this type of a syndrome, just because lack of awareness. People that have damage on the right side of their brain in that region, pretty profound, they can have this very severe form of anosognosia, which is this lack of attention of their environment and their surroundings. They can actually have such a lack of attention and a lack of awareness of their deficits. So if you've got a big middle cerebral artery stroke, I've had patients that have a big middle cerebral artery stroke that knocks out, a wide area like this. So we've got sensory involvement, primary sensory, we got motor involvement, and we've got this area involved. And they will actually be unaware that they actually have a problem on their left side of their body, to the point where they actually think that their left side of their body is actually somebody else's body, and that when they go to get up and walk, and if they fall on the floor, they believe that somebody else tripped them, and they perceive their leg that's tripping them and not doing it as somebody else's body, and they literally get mad at this person. Why does this person keep getting in the way? Or their arm will get caught. They'll be wheeling themselves down the hallway while their arm's getting caught in the wheelchair, and they're taking this, going, if this arm would just quit getting in my way, this person keeps trying to sabotage me and keep getting in my way, literally think it's somebody else's arm, and you literally have to like show them, no, this is your arm, and put them in front of a mirror. And even when you do that, they still struggle with that. And again, that can really slow down your process. And that can even come along with that controversy of pushing, where they're just so unaware of that side of their body. But they're scary because they will just, and they're very spontaneous and impulsive. So there's some impulsivity associated with this too, where they just go and get up, and like if you turn away for a second, they might just stand up, try to walk across the room, just collapse and fall right in front of you. I've had it happen. Fortunately, they did not get hurt. So let's focus a little more specifically on the language disorders that are associated with some of these regions. So we're going to talk about expressive aphasia, also known as Broca's aphasia, aka non-fluent aphasia is what it's called, or expressive, or a motor aphasia. It's the motor output. It's the planning of the motor part of your speech. Okay? This also is true for writing, the language output you use for writing. So if a person has a Broca's aphasia, verbal, they often will have a writing aphasia as well. Those are planned in a similar area. So, but it's not always, if their speech is bad, not always did their writing is the same level. So you might try, see if they can write, and get something out more easily in writing. It doesn't hurt to try. Okay. The problem is, a lot of times when you have a Broca's aphasia, because it's the left side of your brain damage, your right arm is also weak. So they can't write because they have paralysis of their right arm if they're right-handed. So that makes it hard for them to write oftentimes, to get things out, even if they could write. They often have grammatical omissions and errors. They're aware of the disorder. If their Wernicke's area, the area back there in that parietal association, if it's not damaged, if it's just to the Broca's area, they can tell as they're speaking that it's not coming out right. So they get super frustrated. And sometimes, if they have some motor perseveration sometimes with this too, they'll keep trying to say it over and over. They say it wrong, and then they get mad, and they get more anxious and wound up, and they get stressed. And sometimes you have to say, just stop, relax, take a deep breath. You want to encourage them to speak. You don't want to always finish their sentences for them. I got in the habit of that sometimes when they're trying to get something out, and I just start finishing their sentences. It's really hard because you're trying to like be patient, but you still got to get your therapy done. And you want to give them an opportunity to try to use their speech skills and those kind of things, give them some time. But at some point, it's like, let's just shut up and go. We got to get moving. We got to get our walking in, or we get on this treadmill or something like that. But that's where you talk to the speech therapist. There's certain strategies that I can use to be helpful during my therapy session that allow little tricks or what's working for you in therapy that can help them express themselves better. The good part about Broca's, though, is that they understand you. They can follow your directions and commands, so it's actually almost a little easier to work with these patients from a standpoint of following therapy, understanding therapy, reading your notes if you want to give them written kind of things or instructions or pictures for exercises. They have no problem with that. Okay. So here's a couple videos of a young woman who had a stroke, it's kind of neat because and to find and call this Broca's aphasia. So this person had pure Broca's motor aphasia, and then after they passed away, dissected, and this is the lesion you can see is right in that area, that motor planning area for speech. Now, Wernicke's aphasia is also known as fluent aphasia, or receptive aphasia, or sensory aphasia. So these people can actually get lots of words out. They're just gibberish. They don't mean anything, but they can speak them fluently, but they can't put them together in an appropriate way because they actually can't understand what they're saying to check themselves, to check that they're actually saying something meaningful. So but their Broca's area, they can just spit out word after word, and they can just throw them together, and they don't sound like they're having any trouble. But all of a sudden, you're like, wait, that made no sense what they just said. And sometimes you're wondering, am I the one crazy, or are they the one that's kind of crazy here with their... The other thing is that they don't follow your directions very well because they can't understand what you're trying to tell them. They may try to fake it, do their best. But oftentimes these patients, you're doing a lot of we're gonna stand up, we're gonna go for a walk, let's do this, or you're doing a lot of demonstration and trying to get them to follow that. So if it's a real mild case, they might just have some word substitution. And they seem somewhat unaware of the disorder because they can't even check themselves. They don't even know that what they're saying is not the right thing because they don't have the ability to understand that they're not saying the right thing. So they just kind of go. And some of them is very interesting as they will actually sometimes will say a curse word over and over again. But it's a beautifully sounding curse word, and they can say it very well, but they'll say it 100 times in a row. F, 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 chit, 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 chit. And I actually had a patient who was like that and who came from a very conservative religious background, and the poor family members were just like, oh my God, grandma, and the little grandkids are in there, and she's just cussing repeatedly, hundreds of times saying the F word over and over again, because some of those more primitive words like that are stored in your limbic system, and if your limbic system isn't damaged, you can access those words easier than other types of words and so forth. So, and that's true also with some broca's. Sometimes they can tap into that as well. So this is a kind of a neat little example here that.
Like slow down and try writing. Is it a little bit better, or is that kind of the same thing?
Can't be the same thing. Yeah, I mean, they'll have to slow down, but it still will just come out as random words, possibly. Maybe better, you never know. So you always try the writing. There's a thing called conduction aphasia. Yeah. Oh, yeah. Their thoughts are normal. They know what they want to say, but they can't get it to come out right. Yeah, so he thinks, and they actually think what they're saying makes sense because they can't check that it doesn't make sense. And so it's interesting is when sometimes these people get really frustrated that you can't understand them because they think it's perfectly clear. They'll go, blah, 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 just randomly, and they'll go, come on, and you're going, I don't know, and they think you're dumb. You're like, what's your problem, man? What I'm saying, I think that in their brain, they think it's coming out clearly because they can't self-check it. So. Conduction aphasia, this is damage to this thing called the arcuate fasciculus, which is an association fiber that runs from the Wernicke's area to Broca's area. They have the normal ability to understand language because Wernicke's area is okay, but they have difficulty with producing meaningful speech because they can't, especially when they're in conversation, because information comes in to Wernicke's area, you process it, you can understand what they're saying, but you can't then send that thing to your Broca's area to respond with the right sequence and the right words to respond to what was said to you. And so they have difficulty with producing meaningful speech during conversation, okay? Because they're just struggling to they can understand you, but they can't send the signal to Broca's area to respond appropriately. And they also can't, if you do direct repetition, like repeating, say, repeat after me, ball, car, they understand it, but they can't send the signal to immediately repeat it. They can sometimes come up with spontaneous thoughts and and say things that are meaningful sometimes, but it's much harder when they're in this conversation where they're having to interact with somebody and go back and forth because they can't get Wernicke's and Broca's area to sync up and communicate very well. Then there's global aphasia. Global aphasia is the worst because you've got a massive middle cerebral artery stroke typically that's blocking Broca's area, the arcuate fasciculus, and Wernicke's area. You've damaged both Wernicke's and Broca's, so they can't understand you and they can't express themselves. So those people are really difficult and challenging to work with. So here's, Wernicke's area, and some people have it extending all the way up into here. But this is that arcuate fasciculus. So when you hear something, you make sense of it, but then you send that signal here to Broca's area to release and say the right things to respond to that. If you have damage here in that arcuate fasciculus, that is going to cause that conduction because you can't conduct from Wernicke's area to Broca's area effectively. Okay, so again, we're talking about, these are all 95% of the time we have our left side of this would be all left-sided lesions. Another thing that comes along with these is alexia, which is the inability to comprehend written language, which is common with Wernicke's aphasia, and then agraphia, which is inability to write, which is common with Broca's aphasia. So those are commonly associated with both of those. Neglect. Neglect is where you have a tendency to behave as if one side of the body does not exist. I've already mentioned this. Usually associated with right-sided lesions, right parietal lobe damage, in that parietal association cortices. We have personal neglect, which is sometimes referred to as hemi-inattention, where they can have inattention to one side of the environment and even one side of their body. So that's a hemi-inattention, personal neglect. And then the anosognosia is a very severe form of personal neglect. Basically, without awareness is what that means. Is that they actually denial disability and severe personal neglect is this anosognosia. So it's a very severe form of personal neglect or hemi-inattention. And also they have some spatial neglect. So there's the inattention to your own body, that's part of this, but then there's the inattention to the actual environment, which is the spatial neglect. And just they'll be walking and wham, hit the corner of a wall or something like that. Even though you tested their visual fields and they have normal vision, they just, when they're stimulated and there's in the environment, they're just less aware. They're going to be much more dominantly looking and focusing on this side of their body, because oftentimes they have sensory deficits. They have some numbness and so forth, plus they've got some visual field cuts where they maybe are having a homonymous hemianopsia, plus they just, even when you get them to turn their head over this way to look to this area, it's still just harder for them to appreciate their surroundings on that side of their body. And I've had a lot of patients, I don't want to say a lot, but a fair number, that the only thing that kept them from being independent for the rest of their life was that personal neglect. They could just never get good enough at seeing that thing that they're going to trip over, running into that wall. So they walked pretty well. They could do things fairly independently for the most part, but they would just, somebody always had to be with them wherever they went, because they had to get some cueing to not run into that wall or to see that object, or else they were just going to go down and go down hard. So there was a big safety issue, which was sad. I mean, that was like the only thing holding them back from actually being independent, was that lack of awareness or attention. Now sometimes people, they can use like prism glasses, where they put glasses that shift your vision so that you are more aware of this side, but those have their drawbacks too. You got to remember to put them on, but also they can change and alter your vision, so that can be a little safety issue too. But for some people they work, and sometimes you can do things like you actually block their vision on their good side, so that you actually force them to look. So taking glasses, and I would tape on like little blinders on the side, or have them, you know, like you can buy those little things, these little safety things, or you just a little bit of construction paper or something you can tape on, or actually do a little blinder system so that they have to tend to this side and they can't keep, you know, although they're bad, they'll just keep turning their head till they see that side of their, you know, their body and so forth. That's actually the blinders have worked for me a couple times, just doing something simple like that. Lateral pulsion, I mentioned in that earlier in the slide. This is that controversive pushing. Pushing from the less paretic side towards the paretic side is typical, is that they push with their good side towards their weak side. The posterior lateral thalamus or the vestibular nuclei, if you have damage to either one of those could lead to this controversial